well as organizing committee to give me this opportunity to be here with you. And we have talked about climate change and other things, bad effect of climate change. And I will tell you, I had a pleasant climate change. I'm coming from area of harsh winter to this nice sunny weather. So thank you again to organizing committee for this nice hospitality. So as you can see, there is some change in title. So this was what I proposed to mention, that is it time for us to change our standard of care in the management of lupus nephritis. So what is the standard of care as of now? So whenever lupus patient present with this kind of finding, that any new onset of proteinuria which is more than 500 milligram, active sediments in urine or renal dysfunction, then we think that this patient is developing lupus nephritis. So the first step is to do a kidney biopsy, and on basis of kidney biopsy we divide mainly into two broader categories, whether it is proliferative lupus nephritis or it is a non-proliferative lupus nephritis. In about 5% of cases we can have non-lupus related causes, like it has been mentioned here. Sorry. So once we have biopsied and we decide that what is the kind of lupus nephritis, then we decide on the treatment aspect, and treatment is again broadly divided into two aspects. One is the non-immunosuppressive therapy, which includes something like HCQS or ACE inhibitor, ARB, and nowadays fluozins, and then this non-immunosuppressive therapy is continued for lifelong. And then there is a immunosuppressive therapy which is decided on the basis of whether we are dealing with proliferative or non-proliferative, and this immunosuppressive therapy is again divided into two broader categories, that is induction therapy, which is usually given for 6 to 12 months, and a maintenance therapy which is usually given for 3 to 5 years or maybe lifelong depending on patient's outcome. If patient is in complete remission for next 3 years or so, we may try to taper and stop this immunosuppressive therapy. And when we give this kind of therapy, what are our goals? The goals is to bring the disease under remission so that it does not damage kidney. We plan to prevent the long-term outcome, and we plan to prevent the flares, because each episode of flare is said to similar to be like an acute kidney injury episode and causing nephron loss and further damaging the remnant whatever preserved kidney function is there. And not only that, we also aim to minimize the treatment related harms as well as improve quality of life. So as I have said, we decide on induction and then followed by maintenance therapy. And this is, and mostly the changes has occurred in the proliferative lupus nephritis. So non-proliferative, by non-proliferative we mean class 1 and 2, where only if there is nephrotic range proteinuria we give steroids or other immunosuppressive therapy. And similarly in class 5 the guidelines say that only in nephrotic range proteinuria you have to give immunosuppressive therapy, or if there are extrarenal manifestations then you have to give immunosuppressive therapy. But if it is a proliferative lupus nephritis, then always, whether it is nephrotic range proteinuria or mild proteinuria, say 800, 900 milligram, we have to give immunosuppressive therapy. So broadly two categories again, MMF or cyclophosphamide, and in cyclophosphamide again two categories. So everything is going by a factor of 2. So in cyclophosphamide you can decide on low dose, which is given every 15 days, or a monthly high dose cyclophosphamide, which is reserved for severe kind of cases. So by and large we are left with two broader categories of immunosuppressive therapy. One is mycophenolate mofetil and second is low dose IV cyclophosphamide, and we have to give steroid in addition to these two therapies, which is usually given for typical of 6 months, but you can extend it to 9 months or 12 months depending on again patient's outcome, and then you switch these patients to maintenance therapy. So this is what is our current standard of care. Now what are the problems with this current standard of care? So as you can see, what have been reported from the literature, the current response rate are at the best 50%. From India we have slightly better response rate in the tune of around 70%. So approximately 1/3 of your patients will not be responding to this standard of care. So what we call as a resistant disease, or if they have not responded to even 2 standard of cares, then we call this as a refractory disease. And then we switch these patients to some alternative therapy. Similarly, when we give cyclophosphamide, there is always fear of cyclophosphamide-induced toxicity. When we give steroid, we have always fear of steroid-induced toxicity. And also, many of our patients will require lifelong kind of immunosuppression. There will be selected 10 to 20% of cases where we'll be able to taper and stop immunosuppression. So these are the problems, and that is why people have tried to come out with any advances in kidney management in patients of lupus nephritis in last decade or so has seen plethora of such new advances happening. So what are those advances which has happened? So these are like multi-target therapy. What we call as multi-target therapy is basically combination of a calcineurin inhibitor in addition to mycophenolate, mofetil and steroid. They can be B-cell targeted therapy like rituximab and now obinutuzumab. There is Bliss targeted therapy which we known as belimumab, and we have interferon targeted therapy, and there are so many other biologicals which are also under pipeline of various stages of research development. So we'll see some of the most important studies with this, and then what the latest guidelines are saying. So coming to multi-target therapy. So multi-target therapy, initially there were various small studies mainly focusing on class 5 till this study came in 2015 in Annals, which was a fairly large study where these patients were divided into two groups. One group was receiving TAC, MMF and steroid, and second group was receiving IV cyclophosphamide. And what did this trial show? That comparatively tacrolimus was as good as your IV cyclophosphamide group. In some cases, it was even performing better than your cyclophosphamide. So that is why they said that your MTT response rate are as good as IV cyclophosphamide and avoiding the toxicity of IV cyclophosphamide. And that is why the authors said that MTT should be given in your patients of lupus nephritis. But there were problems with this trial. What were the problems? The problem was, number one was the side effects. So there were more incidents of infection. There were more incidents of new onset of diabetes mellitus in patients who were receiving tacrolimus. So in contrast to cyclophosphamide, where you are expecting more infection, it was more actually in MTT group. And other problem was this, that this trial was followed up for another two years or so. And these patients were continued on tacrolimus based maintenance therapy for next 1.5 years. But what the authors have shown that as the time period progresses, like you can see here, whatever advantage of tacrolimus was there in the initial period get lost over progressive period of follow-up. So whatever initial advantage of tacrolimus, it loses its efficacy over longer period of time. Simultaneously, from our transplant experience, we also know that there is a problem of CNI nephrotoxicity which occurs in these patients if we give them for a longer period of time. So that is why people were searching for newer and newer kind of therapy, and then this trial came which was about voclosporin. This was the first trial which was a dose finding kind of a study, which was Aura LV trial, where patients, approximately 200 patients, were randomized into 3 groups. One group was receiving MMF and steroids, second group was receiving low dose voclosporin, that is 23.7 milligram twice a day, and third group was receiving high dose voclosporin, that is 39.5 milligram twice a day. What was more impressive about this trial was this aggressive steroid tapering which was done in these patients, and by the end of 4 months or so, all these patients were on 2.5 milligrams of steroid, which was very, very aggressive tapering of steroid. And what does this trial show? That addition of voclosporin improved the response rate in these patients, and the low dose was more effective as compared to high dose, and the efficacy, the points changes was more significant in the low dose group, that is 23.7 milligram twice a day, and that is how this dose came, that we should be using 23.7 milligram. So the authors went on to do subsequent study which we call as Aurora 1. So what was Aurora 1? So in Aurora 1, more patients were included, and these was around 350 plus patients were included, and now they have randomized only to 2 groups because they were sure about the dose. It was 23.7 milligram twice a day, and compared it with standard of care which was mycophenolate mofetil. And again with this trial they have shown that there was improvement in the outcome if with addition of voclosporin. So this was the outcome of Aurora 1, that addition of voclosporin helps in all the classes of of lupus nephritis. But what are the problems which we have seen in tacrolimus? Does the same problem occur with voclosporin? So the authors have said that in the first trial, in the Aurora 1, there was no difference in the infection rates or anything like diabetes in between the two groups. So the initial problems of tacrolimus trial was not there. What about the long-term follow-up? So the authors conducted or continued these patients or continued this study for another 2 to 3 years or so, and this is known as Aurora 2 trial. So in Aurora 2 trial, the same patients who were on Aurora 1 were followed up for a longer period of time, and what they have shown that despite 3 years of therapy, their kidney functions was preserved. So there was no effect of CNI toxicity kind of thing. Only limitation is that we don't have biopsy in these patients. The another effect what they have seen is that the difference in proteinuria which went away in tacrolimus over a period of time was still maintained in voclosporin group. So there was nothing like CNI dependency or something like that, that the effect of CNI vanishes over a period of time, they did not observe. So these were the two important differences as compared to tacrolimus. And that is why they said that the voclosporin is effective as well as safe at least for 3 years period. And this is the table of same that eGFR, there was no significant difference in the two groups despite better control of proteinuria. So you can take it in a positive manner, you can take it in a negative manner also. Positive manner is that there was no effect of CNI toxicity. Negative is that despite good control of proteinuria, GFR was still same, but this was a shorter term, like 3 years of study. What about B-cell therapy? So B-cell therapy, we have predominantly two therapies, rituximab, and recently we have new data on obinutuzumab. So rituximab, we all know that this was the LUNAR trial, which was a negative trial, and they failed to show any positive effect of addition of rituximab. And that is what is the experience of most of us also in our clinical practice, that when we give rituximab, as compared to your ANCA vasculitis patients, the rituximab usually don't work very well in our lupus nephritis patient. Right? Somehow there will be some improvement, but subsequently they will be back to square one. So why it happens with rituximab? Because the CD19 depletion is not very effective with rituximab, and this is kind of a subgroup analysis of rituximab data, and they have shown that in those patients in whom there was a good CD19 depletion versus those patients whom there was no good CD19 depletion, the response rate was much better in patient who achieved a CD19 depletion. So as you can see here, so 47% was response rate if there was CD19 depletion versus just 13%. So the idea is to deplete your CD19 rather than just giving fixed doses of rituximab if you are using rituximab at all. Then this another drug came which is known as obinutuzumab, which is again CD19 depleting antibody. The nobility trial was presented in ASN and subsequently was published. A small trial, relatively 120 patients or so, and patients were randomized to receive MMF plus steroid versus addition of obinutuzumab. And the obinutuzumab was given at day 1 and then day 15, and then after 6 months again 2 doses was given of 1 gram each. And what they have shown is that the response rate was significantly better. Unlike rituximab LUNAR trial, the response rate were better with obinutuzumab, and many like you can see at the end of 52 weeks, which was their primary outcome, 56% versus 36%, and then at 76 weeks it was still maintained. So good drug to use, and they have also shown that all the parameters were significantly better in this obinutuzumab arm, whether it was clinical remission, whether it was a serological remission, like you talk about anti-DS DNA or complement level or whatever. So good drug to be used, and what they have also shown that when they compared with the historical controls of LUNAR patient, there was significantly better depletion of CD19 with this obinutuzumab, and that is the reason why this drug is working better in your lupus nephritis patient. As I have said previously, the target is to deplete your CD19 and not just to use fixed doses, and this drug was very effective. But again, there are problems with this drug. What is the problem? The problem is this: there are only limited number of B cells which expresses CD19, and as this cells matures and goes towards plasma cells, they loses their CD19 and start gaining their BLyS. What is BLyS? BLyS, which is B cell activating factor. right? Or BAF we can also say. So what happens is that they start losing their CD20. So you are targeting a drug which is acting only on this cells of B cell, while these cells are remaining relatively unaffected and plasma cell is totally not affected at all by use of this drug, and that is why belimumab came into picture, which was a anti-B cell activating BAFF anti-B cell activating factor. And there were earlier studies of Bliss 52 and Bliss 56, which was a non-lupus nephritis patient. They were just lupus patient but not nephritis, and they have shown that this was protective for development of lupus nephritis also, and that is why people have decided to do a trial which was dedicated to lupus nephritis, and this we all know as Bliss LN trial. So this was a very large trial, 450 patients randomized to two groups. One was the standard of care, and another reference was, unlike other trials where standard of care was just MMF and steroids, here the standard of care was MMF steroid as well as IV cyclophosphamide. So it was left to clinicians' discretion what you want to use, and it is actually a good thing to do because some patients we may not like to give mycophenolate mofetil. On top of that, belimumab was added. So first 2 doses was given 2 weekly, and then every monthly doses were given, and these patients were followed up. And what this trial has shown is that these patients were around 450, and another thing was 50% were Asians. So there were no center which was there in India, but there were some Indian patients recruited from outside countries. So there were some Indian Asian patients also in this trial. And what this trial clearly showed is that addition of belimumab was better in terms of your response rate, and they have coined a new term, that is primary efficacy response rate, where proteinuria instead of classical 500 milligram in this trial it was taken as 700 milligram, because the author felt that 700 milligram is as good as 500 milligram. So primary efficacy renal response was better maintained. In a subgroup analysis, they have shown that this response difference was much clearer in patients who received MMF, but it was not significant in patients who received cyclophosphamide. So addition of belimumab over cyclophosphamide may not help much, right, as compared to mycophenolate mofetil. And then another subgroup analysis was done, and what they have shown that addition of belimumab also prevents further decline in GFR. Belimumab treated patient at lower rate of decline in GFR, and they had also reduced flare rate. So addition of belimumab not only improves your initial outcome, they also prevent the flares, and they also prevent the decline in GFR. And this is the table from this subgroup analysis. What is important in this table is that if you focus on class 5, then again the response of belimumab is not good on class 5 as compared to the proliferative classes. So it's better to use belimumab in proliferative classes as compared to non-proliferative class, because the response is not good in non-proliferative class. Then this trial was also extended for a longer period of time, and this time it was a open label rather than blinded trial, and they said that despite extension of this trial, the patients continue to maintain the renal response, and that is why again in the guidelines which I will be showing you subsequently, they have said that if you are using belimumab, you continue using belimumab for a longer period of time. And this was another analysis of belimumab where they have clearly shown that addition of belimumab, if you are using IV, they significantly, that is 3-fold reduction in the flare rates in patients of lupus nephritis. And as I have said previously, we have to prevent flare because each flare acts like an acute kidney injury episode and damages your nephrons. So you have to prevent flares, and prevention in flares, this drug is very, very effective. So having presented to you all this data, what are now guidelines saying? Have they changed their outcome in terms of standard of care? So the first guideline to update themselves was this Glosen guideline, which are a Spanish guideline of glomerulonephritis nephrologist group. And what they have shown is that they have divided patients into that induction therapy. Now you can use the classical double therapy, which I have said earlier, or you can use triple therapy. Now triple therapy, in addition to your standard of care, you can add either voclosporin, or you can can add belimumab. And you can decide depending on availability, depending on affordability, and depending on some clinical features which I'll subsequently refer to, then in which patient you should preferably be using voclosporin and in which patient you should be preferably be using belimumab. So this was the first update, and subsequently KDIGO has come up with this update in the guideline in management of lupus nephritis, again similar to the Spanish guideline, that they have said that we can use this triple drug therapy in induction patients. And also, if you are using this newer drug therapy in induction, you have to continue, like CNI, if you are using voclosporin, you can continue it up to 3 years. So your maintenance will also include that therapy, right? And similarly, if you are using belimumab, you continue using belimumab for up to 2.5 years. So your maintenance therapy will include belimumab. So the classical timeline of 6 months, 12 months has been extended to 2.5 to 3 years. Also, the KDIGO guidelines said that people are now very worried about steroid toxicity and steroid dosing, and they are very, very aggressive, as I have said, in voclosporin trial on steroid tapering, which was not done in the BLISS trial. It was the conventional taper only, but still the guidelines have said that you can decide to give a moderate dose or a low dose kind of steroids, not clearly defined that in which patient we should be using low dose or moderate dose, but they have said that we can individualize our patient and use moderate or low dose of steroids. And the third guideline which was updated was ACR guideline, EULAR guidelines, which has been published just this month in January 2024. Again, similar to the previous two guidelines, what they have shown is that you continue your non-immunosuppressive therapy, you give steroid, pulse steroid, followed by a low dose of steroid, that is 0.3 to 0.5. Again, this is similar to what KDIGO has also mentioned in their low dose and moderate dose, that your steroid dose cannot be like 0.8 to 1 mg. It has to be something like 0.3 to 0.5 milligram. And then if you are giving MMF, you continue MMF as maintenance therapy. If you are giving low dose cyclophosphamide, you can either give azathioprine or mycophenolate mofetil as maintenance therapy. However, if you are using triple drug therapy, as I have said in KDIGO guidelines, these guidelines also say that your maintenance therapy should include whatever triple drug therapy you have used in the induction period, because to prevent the flare rates and protection of renal function. So now the question comes, we have broadly two categories, belimumab and voclosporin, if we want to use triple therapy. So which drug should be used in which patient? So this is broad comparison of these two drugs. The topmost is what I have already presented. As I have said, cyclophosphamide was given as induction therapy in BLISS-LN trial, but voclosporin patients were predominantly were always on mycophenolate mofetil. So we don't have data on addition of voclosporin on cyclophosphamide. In BLISS-LN, the addition of belimumab over cyclophosphamide did not help much. Okay, class 5 proteinuria patient, it is better to give voclosporin to control your proteinuria immediately. If you have proliferative, lot of extrarenal manifestation, it is better to give your belimumab because it controls your disease activity. Flare rates, we have definite data that flare rates are reduced with belimumab. We don't have such kind of data with voclosporin. Adverse event, similar in belimumab group. Voclosporin also said that similar kind of adverse event with slight increase in infection rate on their longer term of follow-up. What about EGFR, which is less than 45? Now, voclosporin is contraindicated if you have EGFR of less than 45 because FDA is not approved in this kind of patient. But belimumab have been used till EGFR of 30 mils per minute, right? So in pregnancy, none of these drugs are recommended. Both of drugs are contraindicated. So depending on your patient profile, you can decide which drug to be used. Similarly, the KDIGO also said that you can decide on a step-up kind of therapy, or you start with triple drug immunosuppression. So you can start some patient on your conventional dual drug immunotherapy, and then if patients are not responding, you can add on the therapy. However, the disadvantages are that this kind of a step-up approach has not been studied. What has been studied is the upfront uses. So we don't know whether later addition of these drugs will be helpful or not, right? So we may be losing the precious time. So what is the recommendation is that if you have to use this triple drug therapy, you have to use them upfront rather than a step-up kind of approach. So there are many drugs which are coming in pipeline, which are in various stages of research, various phases of study, and some of these drugs are mentioned in this diagram, but this diagram is still not complete. There are many drugs which have been missed on this, but there are two important drugs two important therapies which are coming in a big way. One is obviously this interferon targeted therapy, which is your anifrolumab, and there have been two studies which have come out, and they have shown that addition of anifrolumab to your standard of care may be helpful in your patient of lupus nephritis. But what is interesting is that if you can somehow judge their interferon signature, and if their interferon signature is high, and if you give anifrolumab, the effect of anifrolumab is much more as compared to if your interferon signature is not high. So you can actually have a targeted kind of therapy rather than blindly giving everyone a triple therapy. So you study their interferon levels. If interferon levels are high, you give anifrolumab. So this was TULIP study. The difference was not significant, but they are conducting another study, which is IRIS study, and maybe we will come out with a positive result. Another therapy which is coming up in a big way is this CAR-T, which is reserved for refractory kind of patient, very, very toxic therapy, very, very expensive therapy, and also FDA has issued a recent warning with this therapy that giving this kind of therapy increases the chances of malignancy, particularly hematological malignancy. So we are still not sure what will be the long-term outcome with this therapy. So to conclude, as I have said you, management of lupus nephritis, especially in last decade or so, is changing rapidly, especially in the proliferative lupus nephritis class 3, 4 or combinations. And world is moving. All the guidelines have updated themselves towards the use of triple drug immunosuppression over double drug immunosuppression. However, what we should be doing, in India we don't have availability of this drug officially, and these drugs are also said to be very, very expensive. However, if you check online on something like IndiaMart or 1mg or something online pharmacy or so, both of these drugs are available actually. I am not sure how they are available, and I am not sure about the cost also, because if you check online, the dose of 7.9 milligram of voclosporin is available. 60 tablets are available at the cost of 500 rupees. So you have to give 3 drugs in the morning and 3 drugs in the evening, so 6 tablets. So cost of therapy comes to around just 50 rupees a day. You know, so 50 rupees a day is 1500 rupees a month, which is very, very cheap. I am not sure whether we are getting genuine drug. I am not tried myself ordering themselves from IndiaMart or 1mg. Similarly, if you look at Benelista, the cost of 200 milligram injection is available at 6,500. So you have to give 3 injections. So still it is coming at 18,000 rupees monthly therapy, which is again not very expensive as has been projected, but still I am not sure the quality whether we are giving. It's officially not available in our country. So non-availability as well as high cost will preclude. So as I've said, many drugs are available in pipeline. Will come out with data in next few years or so. Some of these studies are being conducted in India also, and many of you may be part of those studies, and we will come out with the Indian data also. So the question was, is it time to move beyond the current standard of care, which is dual immunosuppressive therapy in India? Particularly, I don't feel so, because officially we don't have these drugs. We don't have any Indian data to support the use in Indian patients, and we have a problem with the cost also, although I have said the online availability. So as of now, we should be sticking with the dual immunosuppressive therapy. So thank you very much for your patient hearing. Happy to take questions.